Welcome. I'm Kim Tranquata, the CEO and founder of the Healthcare Alliance for an Equitable World, and your host on this journey. Our organization, driven by clinicians, is on a mission to address global healthcare inequity using telehealth solutions. Together, we're building a community of healthcare professionals committed to making scalable impact on global equity. Join me in insightful conversations with global health innovators as we explore the current and future state of healthcare. Please be a part of the mission. Let's create lasting change together. And today it is my honest pleasure to introduce Dr. Alan Greenglass. Dr. Greenglass is an internal medicine trained physician, earned his MD, and did his residency at Brown University. He has worked as a primary care physician, a medical group executive, a senior VP at Christiana Care, and was a co-founder of that health system's program on health disparities and equity. Since his retirement, Alan has turned his attention to climate and health issues in Delaware and the surrounding region. He's founded the Mid-Atlantic Alliance for Climate and Health, MAACH, and is working on environmental justice and health issues. Alan is also the author of a recent book, Curing Physician Management: Why Physician Managers Fail. It's my pleasure to welcome you to the podcast, Alan.
Well, thank you very much. I'm glad to have the opportunity to speak with you.
We're excited to hear more. Before we begin our conversation, I always like to offer our guests the opportunity to identify any disclaimers or conflicts of interest.
Nope, everything I'm doing is totally voluntary. So thank you.
Awesome. Thank you. Thank you. Well, let's start with a little bit about you and how you started this very successful and wide-ranging journey as a physician. Tell us a little bit about your background and how you got involved in not just healthcare, but health equity.
Well, yeah, just to clarify, it's not always been successful. And actually, if anybody has the opportunity to read the book, which is not the main focus of what we're speaking about now, it contains many stories of things that didn't work out quite so well in my career. So, because healthcare is a challenge. I grew up, went to college during the 60s and the early 70s. I decided to go into medicine because I thought it was a way that I could have an influence upon social well-being of folks in the society. And that's what also led me to primary care. And during my medical school, I was fortunate to be exposed to the health maintenance organization movement and also work being done by folks like Ted Kennedy on Medicare and Medicaid. And I think many of us don't remember that before the mid or late 60s, people who could not afford to buy health insurance or people who were older were basically left on their own in a kind of a fee-for-service environment. And so I viewed that as something that I wanted to work on. And from the beginning, I thought that I wanted to do primary care, but I also wanted to have an impact beyond just the one-on-one patient experience, which is obviously crucial and the cornerstone of primary care and the relationships you develop over the course of years with your patients and their families. But I want to do something more than that, and that led me into management. And I realized pretty early that there's a limit to how we can impact people's health and well-being just by that 15 or 30 minutes in the office. And I think that's been shown by research more recently, that the biggest impacts upon people's health are their living conditions, their environments. And that led me to study and learn a little bit more about population health, social determinants of health. And actually, I was very fortunate because for most of my practice career, I worked for Kaiser Permanents, which really invests in its people and in its patients in terms of preventive care, understanding where they come from, what risks they have, and how to mitigate those risks as best as possible. And that led me to the health disparity and equity issues. I worked for a very open-minded, progressive physician as the CEO at Christiana Care, which is in Delaware. Uh, Initially, I worked in Connecticut and Rhode Island for many years, and then came to Christiana Care. And I realized that, for example, even though we lived in a community with a large minority population, and even though we were are still the predominant healthcare provider for 30 miles in any direction, uh, that there were no interpreters in our hospital. And this wasn't so long ago, it was probably around 12 years ago. So when folks came into the emergency room and they didn't speak English, it was kind of like that sign language process. And you may be familiar with that from earlier in your career because you've worked in emergency rooms. And the idea was to treat and street and not really take too much, pay too much attention to what the true story was and how to prevent that person from coming back or being well once he left the emergency room. And so I was able to convince our CEO to send me and a fellow physician to Boston to the Massachusetts General Hospital program on health disparities, and came back with a lot of ideas. And I guess against the resistance of many folks who were more concerned about sometimes the bottom line and efficiency rather than efficacy of healthcare, we were able to convince the program to take a number of steps in terms of health, what we came to call health equity, not just health disparities, but focusing on the positive things we could do to improve the likelihood that people were going to be healthy. And and that's how I came to it. And I guess just to make a point, to me, healthcare equity means being sure that people are treated well once they come to the hospital, for example, or to a medical office. So if they're in pain, that they get adequate pain relief, they get adequate testing. They don't spend more time in the emergency room or hospital than they need to because people can't communicate with them. But health equity, I think, goes beyond that. It goes to saying, yes, we might treat you well in the emergency room for your asthma, but what's causing your asthma? And what can we do as a society and maybe as a health system to make it less likely that asthma is going to bother you in the future and that you're going to need to come back to the emergency room again? So I make that differentiation, and that's what we try to do, and I'm trying to do now in my career, is to get beyond what's done in the healthcare setting to what can we do to prevent people from needing as much healthcare intervention.
I love that trajectory. Like, there's a couple things in there that you bring that's super unique, perspective wise. Your perspective of healthcare pre-Medicare and Medicaid. I think in current times, Medicare and Medicaid get a lot of negative publicity and press. And I think your perspective about where things were before those programs existed and how those programs were able to bring people into healthcare without taking away from the fact that we always want things to get better and we want more, right? And I think that's what's happening now in the post-Medicare, Medicaid era. So I think that's amazing. Also, I wanted to, talk a little bit about the translation issue. It is required now that all ERs have some sort of online translation accessible, but it really is quite far from the promise. Often that is something that will take quite some time to get somebody on the line to do. For some languages, it is difficult to get the appropriate translator. And then when you get them, I think what we don't realize is medicine doesn't happen in one conversation. You don't just talk to the patient and it's over, especially in an emergency. we're checking in regularly with the patient, giving them updates, getting updates from them on how they're doing. It's a really important part of carrying out that care. And that's really hard to do with these online translation programs. So we're making progress, but we're definitely not at the, hey, we got equity with medical translation part.
Yeah, I agree. And, I've been reminded that really we don't want just translation. We want interpretation. We want somebody who understands the culture as well as the words which are being said. And when I came back from Boston and learned about best practices in terms of health equity, uh, the folks who controlled the finances, and our health system was very progressive and very important part of the community, but people who controlled the finances said, "Oh, we're not going to hire interpreters or translators. It's too expensive." And I went to the emergency department, and their leadership said, "No, it's going to slow us down. We just, that if we have to have somebody come in, a person or get somebody on the line to translate, it's just going to slow us down, and we need to get the patients out the door." And but when I talked to the staff, the nurses, and the physicians who were actually doing the work, they said, "We're not doing a good job." And we were able to convince the system to let's do a pilot. We hired 3 people. We put them in the emergency room and in the intensive care unit. And it snowballed because people realized that what they were doing in the past was not good care, and actually slowed things down. If you had to do more testing because you couldn't talk to the patient and get an adequate history. And as you probably know, early on, many of the people who interpreted for patients in emergency settings were the children, because the children were more likely to be bilingual. And so we had 7 or 8 year olds trying to interpret the things that their parents or grandparents didn't want actually to share or let their children know about. So it was awkward, but I think we've come a long distance. And you're right, the online services are not necessarily great, but for some languages, there's such a diverse community now, especially in our urban areas, that you need to be able to have some backup technical resource and can't just depend upon other native speakers to be helping you.
Yeah. And, if there are health systems listening, I would say I love the way you describe it, where the health system hires people to be there in person. Because one of the things that come with translation and cultural understanding is that people are afraid and don't trust the healthcare systems when they come into them because they don't understand them, they don't understand their culture. And when you make the effort to show people that you can have somebody there in person that's translating for them, that you're trying to understand them and empower them in their healthcare, that builds trust with the community, and that helps you provide better healthcare, because otherwise people don't tell you things, you don't necessarily understand what they're trying to tell you, and it leads to bad care.
And when we started this, and there is medical literature talking about the quality of care and even the efficiency of care, which is improved by having translators. I had to convince people that was the case, and then that's why we did a pilot first, and then we showed ourselves, demonstrate to ourselves that what we were doing was able to replicate what people have done in studies at other institutions. That it's not necessarily going to slow you down. It's not going to mean more testing, uh, uh, and as you know, there are groups of people who wait longer in the emergency room to get taken care of. So they can wait long. Their chest pain is not as well diagnosed. They get less pain relief if they've had an injury. They don't get. They have a less frequency of getting appropriate testing. Uh, and so there's still challenges, but I think we've come a long way. And there are people who are kind of leading that work throughout the country, whether it's Kaiser Permanente or Mass General or folks in New York City and elsewhere, realize that We just can't keep doing it the way it was 30 years ago, and it's cost effective.
Yeah, tell us about that. How does it work out to be cost effective?
Well, one is you're not doing inappropriate testing. Two is you're treating you know what you're treating more likely because as you know, and I was not an emergency physician. I was a primary care physician, but at least in primary care, the history gets you 90% of the way. And I have practiced in urgent care settings, and I have the feeling that the history is exceptionally important also. So the more you can focus on being able to deliver appropriate care, but getting back to underdiagnosis of chest pain in women, I know that's not necessarily considered to be a minority, but women are very often treated differently uh, in terms of some of their symptomatology, in terms of Black populations, Hispanic populations underdiagnosis, and that means not having the opportunity to intervene at the appropriate stage, and therefore having the need to have more acute intervention, more expensive intervention later on. It really has been shown to increase the likelihood that people get the most effective and efficient care first pass, rather than having that delayed or having the more morbidity of people getting sicker because they weren't properly taken care of the first time. And sometimes it's not the fault of the nurses and the clinicians who are trying hard, but it's really the system that makes it difficult to get adequate information and break down those stereotypes. Unfortunately, those subconscious stereotypes of these women don't get heart disease, right? Or this population is seeking drugs, so we're not going to give them adequate treatment for their broken ankle.
Yeah, and those stereotypes and or biases are not necessarily in the individual either. They're baked into our medical protocols, our medical research and systems. We study predominantly white males for things like heart disease and stroke, and so when others present and they don't have those symptoms, we've just assumed they don't have it. But maybe we just don't know what their symptoms are like because we haven't studied it. So I don't think it's only at the individual level, it's definitely also at the systemic level. Dr. Greenglass, you obviously bring a lot of advocacy and still very engaged in health equity as now a retired physician. How are you using that need, that urge, that baked in fiduciary responsibility as a physician to the social well-being in your current activities with Mock?
When as I was getting ready to retire, I was kind of thinking what kinds of things I wanted to do, and climate climate change, air quality, water quality has always been very important. And I realized long ago that climate, air pollution, and the environment is a social determinant of health. We think about diet, and we talk about smoking and exercise, but we know that the air you breathe, the water you drink, how hot it is where you live, they all impact people's health. And I started talking to people about it. And I live in a small state, Delaware, where everybody has a kind of a 2-degree separation from the policymakers. So the governor, the senator, the president, that it's people you literally run into on the street, and which I've done multiple times, and so in the course of that, I got involved in attending some legislative hearings about the state committing to renewable energy resources, offshore wind, other things. And I realized there was no healthcare person speaking at all. It was all ideologic. It was all numbers. Wind turbines cost this. Solar costs that. Fossil fuel electricity is some other cost. Nobody was talking about the health implications. And I knew, and I went out and researched this, that it's actually less expensive to invest in clean air than it is to treat the asthma, the heart disease, the pregnancy complications that come from people breathing polluted air or living where there's high ozone levels or extreme heat. And so I started raising my hand to say, hey, do you know that Delaware has one of the highest asthma rates in the country, pediatric asthma rates? And you know what causes that? Ground level ozone, smog. And our levels of that are not good. And do you know Delaware has one of the highest infant mortality rates in the country? Why is that? Well, a lot of that is what happens before people get pregnant, right? It's their access to health care, but some of it is environmental also. And so by starting to make that argument, people start to take health seriously. And because I was raising my hand, I got selected to be involved in a number of different work groups, governor's work group, and state legislative work group. Once again, small state, less than 1 million people. And but in that way, I was able to learn more, understand how policy was made. I'm not an expert in how to make policy, but I've become an expert in how the environment impacts people's health. And I got to talk to people around the country. I was selected by the National Academy of Medicine to be on a task force about health system sustainability. And I was able to talk to people in Philadelphia at the Children's Hospital about a project that they do when they have kids who show up in the emergency room frequently with asthma. They ask the parents, can we come to your house and see if there's something that's causing that kid to get asthma? And to me, that's the difference between equity, healthcare equity, in which kids are getting good care in the emergency room and in the primary care office, and health equity, in which there's an effort to understand why they're getting sick and to see if we can mitigate that. So at CHOP, which is the Children's Hospital in Philadelphia, they've intervened and they've done housing retrofits, insulation, fixing leaks, mold remediation, better air conditioning and heating. So they're improved their indoor air quality. And they've published showing that those kids who they've intervened, whose families in housing they've intervened with, have much less need for asthma medication, many fewer visits to the emergency room for their asthma. And asthma is a little personal to me because I have asthma. I haven't had the problems that many of the people I care of as a physician had. It's never really interfered with my lifestyle, but I understand it well enough and have experienced well enough to know that you don't want to be short of breath because you're in a mold situation or you go out to exercise on a cold day. So I have some empathy for folks and in that situation. But that's part of environmental justice. That's part of health equity, is to say, how can we change things? The heat island effect in our inner cities. We've studied that in Wilmington. And as you know, it's been studied throughout the world. Between the green areas of Wilmington and in urban areas and the less green areas, the places where lower income, middle income people live, it can be a 9 to 12 degree difference on a summer day. And that, along with ground level ozone, diesel school buses, diesel trucks running through lower income neighborhoods, that's going to cause people who are susceptible, older people who work outdoors, younger people, kids with asthma, kids with people with congestive heart failure. That's going to cause them to get sick and show up in our emergency rooms and be an inefficient way to keep people healthy.
Well, I'm going to make what you just said the call to action for this episode, which is healthcare clinicians, please, your voice, your experience, your lived advocacy by knowing how these things affect patients in reality every day needs to be at the table in policy making. Are you aggravated that health policy makes no sense? It's because your voices are not at the table and people are making decisions based on projections that are not based in clinical experience. So take Alan's advice, take Alan's example, and please bring your voice to the table in policymaking. We're going to take a little break and return to part 2 with our conversation with Dr. Alan Greenglass. We have lots of other exciting topics to talk about.